The global healthcare crisis is widely misunderstood. We assume medical science is failing to keep up with disease. In reality, our triage systems have collapsed under the weight of unmanaged demand. Traditional hospital networks treat every inbound patient as a medical inevitability. Yet data shows that between 25 and 40% of primary care and emergency room visits are entirely avoidable. This unnecessary traffic inflicts a staggering operational cost. In the UK alone, the National Health Service runs a projected £6.4 billion deficit, while patients face average wait times of 14.5 days just to secure a general practitioner appointment. These figures reveal a structural bottleneck. The core issue is not a lack of doctors, but a failure to intercept non-urgent cases before they enter the medical pipeline. Pouring capital into more hospital beds treats a symptom of this gridlock. It does nothing to solve the uncontrolled, panic-driven demand occurring at the very top of the funnel. This false demand originates directly from how we search for health information. When we experience ambiguous symptoms, we turn to the internet expecting a neat, transactional answer. Instead, standard algorithmic symptom checkers return worst-case scenarios. A mild headache is processed by rigid decision trees, which instantly output terrifying, fatal diagnoses. Clinical psychologists define this reaction as the disaster movie mind, or catastrophic thinking. The brain takes a minor physical signal and projects the most severe possible outcome without any logical friction. Once this state is triggered, the biological panic response completely overrides emotional regulation. The user cannot simply turn off the screen and go to sleep. Pure algorithms fail here because they ignore human context. They do not factor in external stressors like financial debt, workplace anxiety, or isolation, routinely misclassifying psychological suffering as an acute biological threat. The downstream effects are severe. Terrified individuals rush to emergency departments, exhausting clinical staff and driving a massive surge in antimicrobial resistance, or AMR, as doctors issue panic prescriptions to process the overwhelming queue. Our digital health tools do not calm patients. They act as anxiety multipliers, pushing self-limiting, minor ailments straight into our critical care infrastructure. Fixing this requires an architecture designed to manage fear rather than just label diseases. This is the operational premise of Dr. Maya GPT. The Dr. Maya AI Logic Gate evaluates 3 combined symptoms to build a pattern, distinguishing physical pain from emotional distress. Symptoms map to a 4-color matrix. Green and yellow pathways indicate minor conditions, pointing users towards self-care or a pharmacist. By delivering immediate, validated reassurance, these moderate pathways intercept patients before they leave their homes, safely absorbing massive amounts of hospital demand. The red pathway identifies severe, acute symptoms, directing the user to seek immediate medical intervention. Finally, the blue pathway detects infectious symptoms and advises isolation, cutting the chain of transmission and preventing unnecessary antibiotic use. This framework mirrors the diagnostic approach of an experienced human clinician. It weighs combinations and severities, avoiding the rigid, linear traps of standard decision trees. To maintain patient calm, the AI replaces alarming yes or no questionnaires with logical educational guidance, explaining why a specific pathway is recommended. The software functions as an intelligent circuit breaker. It neutralizes the psychological panic state hours before an ambulance is ever called. Software alone cannot reach the most vulnerable populations. The intelligence must be physically deployed into communities through the Prima Kiosk network. Intercepting systemic bottlenecks requires placing this triage capability directly into the margins, rural villages, isolated neighborhoods, and low-income urban areas. This visual shows a Prima kiosk in an outdoor market. The hardware is touch-free, heavily protected, and operates offline without internet. Crucially, the interface uses audio-visual guidance in over 30 native languages, solving the barrier of widespread illiteracy. An 85-year-old grandmother in rural Karnataka or a Polish construction worker in London can walk up to a terminal and interact securely in their native tongue. This grants millions of individuals autonomous control over their health decisions without requiring smartphone ownership, broadband access, or digital literacy. For economically disadvantaged families, receiving immediate, accurate reassurance eliminates the severe cost of lost wages and transportation required for an unnecessary hospital visit. The physical kiosk acts as a structural bridge. It connects isolated populations to high-level clinical reasoning, closing the economic and literacy gaps that prevent early intervention. Sustaining a physical network of this scale requires a robust financial architecture. Solutions reliant on perpetual charity grants or public debt inevitably stall. The PREMA network operates on a triple-purpose microeconomy designed to generate independent, sustainable revenue. The first 25% of revenue is allocated to commercial returns. This funds ongoing maintenance, software updates, and incentivizes local kiosk operators to expand the network. The next 25% guarantees subsidized access. This ensures that pensioners, asylum seekers, and individuals on universal credit receive free consultations without exception. The remaining 50% flows directly to the Prema Maya Foundation, financing global AMR research and underwriting the deployment of new kiosks in low-income regions across Africa and Southeast Asia. On the ground, these units are managed by trained community health navigators. This creates stable, dignified employment for youth, women, and former health workers within their own neighborhoods, offering a direct alternative to exploitative gig economy labor. The model flips the traditional dynamic. It takes community healthcare, typically a drain on state resources, and turns it into a localized engine for job creation and self-sufficiency. The macroeconomic and operational efficiencies serve one primary goal: arresting the global antimicrobial resistance crisis, an accelerating threat that currently causes over 1 million direct deaths a year. When individuals use the kiosk and receive a blue isolation code, they stay home. Catching these infectious symptoms at the village level prevents highly contagious patients from sitting in crowded hospital waiting rooms. This chart graphs projected annual mortality. The red line tracks standard care, while the lower blue line maps the implementation of the community early detection system, showing a massive reduction in deaths. By intercepting fear before it reaches a doctor, the network discourages the self-medication and unnecessary antibiotic prescribing that directly fuel bacterial resistance. This graph illustrates the cumulative UK lives saved by the network from 2028 to 2050. It demonstrates how early intervention compounds exponentially as the kiosks reach full national coverage. The PREMA network is designed to function as an active, distributed epidemic defense grid, identifying outbreaks before they compromise centralized facilities. It protects patient autonomy, replacing algorithmic terror with logical, color-coded reassurance. Preventing the collapse of our healthcare systems does not require pouring concrete for more hospital beds. It requires engineering a decentralized architecture of reassurance, stopping fear at the source.